Welcome back, everyone, to HTL 312 Ethics and Standards in the Lab. Today we are diving into a topic that is both heavy and incredibly important: mistakes matter. We're going to look at physician ethics and the harsh reality of medical errors. I know, it's not the most uplifting topic for a Tuesday morning, but it's crucial for our field. As histotechnologists, we are often behind the scenes, but our work is front and center when it comes to patient outcomes. We've spent the last few weeks talking about the ideals of ethics and the strict rules of law. We've discussed our responsibilities when everything goes perfectly according to plan. But what happens when the plan falls apart? Today, we apply all that knowledge to the messy, complicated reality of what happens when things go wrong. So grab your coffee, get comfortable, and let's get into it. Before we dive into the heavy stuff, let's contextualize where this lecture fits into HTL 312 as a whole. This course is designed to be the bridge between the theoretical concepts you learn in textbooks and the practical realities you will face on the bench. We've covered the ideals, and now we are looking at the friction points. The goal isn't to scare you, although some of these case studies are certainly sobering. The goal is to prepare you. We want you to walk into your first job not just knowing how to cut a slide, but knowing how to navigate the complex ethical and legal landscape of a modern laboratory. We are building your professional armor today. Think of this lecture as the "What Could Go Wrong?" manual, and trust me, you want to read it before you need it. Let's take a quick look at where we are in the course right now. You've all survived the deep dives into ethical theories and frameworks. You've navigated the dense, sometimes dry, waters of healthcare law and regulations. You've learned about your professional responsibilities and the standards you are expected to uphold every single day in the lab. You know the rules of the road. But knowing the rules is only half the battle. The real test is what you do when there's a crash. Now, we are going to take all of that foundational knowledge and apply it to the real world, specifically when things go wrong. Because, spoiler alert, things will go wrong at some point in your career. It's not a matter of if, but when. And how you handle those moments, how you apply your ethical and legal knowledge, will define you as a professional. We are moving from theory to practice today. Let's face facts. The reality of healthcare is that it is incredibly complex. We are dealing with the human body, which is basically a biological mystery wrapped in an enigma. Decisions often have to be made at lightning speed, sometimes with life or death hanging in the balance. And more often than not, the information we have is incomplete or ambiguous. You might get a tissue sample with a vague clinical history that just says, "lesion. Thanks, doc, very helpful." Because of this complexity, speed, and lack of perfect information, mistakes are not rare. In fact, they are a known and somewhat expected part of the system. We try our best to minimize them, but human error is exactly that, human. Acknowledging that mistakes happen isn't admitting defeat, it's the first step in building systems to catch them before they reach the patient. So, let's drop the illusion of perfection and deal with the reality of our chaotic, high-stakes environment. When a mistake happens, the immediate question is usually, did a mistake happen? But that's just the tip of the iceberg. The bigger issue, the one we really need to focus on, is much deeper. We need to ask, what kind of mistake was it? Was it a slip of the hand, a lapse in judgment, or a systemic failure? Then we have to dig into the root cause. What caused it? Was the tech overworked? Was the equipment faulty? Or was the protocol unclear? And perhaps most importantly, what happens next? How do we respond? How do we fix it? And how do we prevent it from happening again? As histotechs, if a slide is mislabeled, we don't just shrug and say, "Oops." We have to trace that error back to its source and figure out how to stop it from recurring. The "what happens next" is where our ethics truly come into play. It's about accountability and continuous improvement, not just pointing fingers. So, why does all of this matter so much? Why are we spending a whole lecture on it? Because medical errors have profound, real-world consequences. First and foremost, they contribute to patient harm, which is the exact opposite of what we are all here to do. A mixed-up biopsy can lead to a delayed cancer diagnosis or unnecessary surgery, which is a nightmare scenario. Second, errors lead to a massive loss of trust. Patients trust us with their lives, and when we mess up, that trust is shattered, sometimes irreparably. Third, there are severe legal consequences, which we will get into later, but let's just say nobody wants to be deposed in a malpractice suit. But here is the kicker, the silver lining if you will. These errors are often preventable. By understanding how and why mistakes happen, we can build better safeguards. We can be the safety net. That's why this matters, because we have the power to stop the harm before it reaches the patient. Now, let's look at the historical roots of this commitment to patient safety. Let's shift gears and talk about the foundation of medical ethics, which starts with the physicians. We have to look at the Hippocratic Oath, one of the oldest ethical frameworks in medicine. It's been around since ancient Greece, which means it's older than the stains we use in the lab, and arguably better preserved. Despite its age, the core principles are still incredibly relevant today. The most famous takeaway is: first, do no harm, or primum non nocere. This is the bedrock of everything we do in healthcare. Before we try to heal, before we try to diagnose, we must ensure we aren't making things worse. For us in the lab, doing no harm means ensuring our stains are perfect, our cuts are clean, and our labels are accurate. If we provide a subpar slide, we are actively contributing to potential harm. So, we carry that Hippocratic torch just as much as the doctors do. But how has this ancient oath evolved? The original Hippocratic Oath has been modernized over the years, and the version credited to Louis Lasagna in 1964 is widely used today by medical schools including Johns Hopkins and Tufts. This version is notably more human and reflective. It acknowledges that medicine is both an art and a science. It emphasizes humility. I will not be ashamed to say I know not. It recognizes the physician's role in society and the weight of life and death decisions. It even includes a reminder: above all, I must not play at God. That line alone should resonate with every healthcare professional. We are not omnipotent. We are skilled, trained, and dedicated, but we are fallible. The modern oath captures that beautifully. It's a reminder that our ethical obligations are not just technical, they are deeply human. This brings us to a core ethical principle. That concept of first, do no harm has a fancy ethical name: non-maleficence. It is the core ethical principle that dictates we must avoid causing harm to our patients. It sounds simple enough, right? Just don't mess up. But as we've already discussed, the reality of healthcare is far more complicated. Despite our best intentions, despite all the protocols and double checks, harm still happens. It's a bitter pill to swallow. We can be as careful as humanly possible, and a machine might still malfunction, or a reagent might go bad. Non-maleficence isn't just about avoiding intentional harm, it's about being hypervigilant against unintentional harm. It requires us to constantly evaluate our processes and ask, is there a safer way to do this? When harm does occur, our commitment to non-maleficence demands that we investigate it thoroughly. We have to learn from the harm to prevent it from striking twice. It's a continuous, exhausting, but necessary cycle. So, what does this mean for modern physicians? The modern physician carries a massive burden of responsibility. They are expected to diagnose accurately, which, as we know, relies heavily on the quality of the work we produce in the histology lab. If our slides are garbage, their diagnosis might be garbage too. They must also treat appropriately, choosing the right intervention based on that diagnosis. But it doesn't end there. They must follow up consistently. This is a huge area where things fall through the cracks. A doctor might order a test, we process it perfectly, the pathologist reads it perfectly, but if the doctor never follows up on the results with the patient, the whole system fails. The responsibility doesn't stop after the prescription is written or the surgery is done. It's an ongoing relationship. As histotechs, we need to understand this workflow because we are a critical link in that chain. If we delay a result, we delay their ability to follow up, putting the patient at risk. And this all ties back to trust. Let's talk about trust. When a patient enters the healthcare system, they are usually vulnerable and scared. They operate on a set of assumptions. They assume competence, that the people treating them actually know what they are doing. They assume honesty, that they will be told the truth about their condition and their options. And they assume care, that the professionals actually give a damn about their well-being. These are big assumptions, and they form the foundation of the patient-provider relationship. But here is the harsh truth: errors break that trust incredibly quickly. It takes years to build a reputation for excellence, and only one major mistake to tear it down. If a patient finds out their biopsy was mixed up with someone else's, all that assumed competence and care evaporates instantly. Rebuilding that trust is nearly impossible. That's why our precision in the lab isn't just about good science. It's about protecting the sacred trust patients place in the entire healthcare system. Now, let's consider how our ethical obligations differ from legal requirements. It's important to distinguish between ethics and the law, because they are not the same thing, even though they often hang out at the same parties. The law dictates what you must do. It's the baseline, the minimum standard of behavior required to avoid getting sued or going to jail. Ethics, on the other hand, dictates what you should do. It's about moral principles and doing the right thing, even when no one is looking. Now, these two concepts often overlap. For example, stealing a patient's medication is both illegal and unethical. But they don't always align perfectly. Sometimes, a law might seem unethical, or an ethical action might not be strictly required by law. In the lab, the law might say we have to keep records for a certain number of years. Ethics says we should ensure those records are meticulously accurate and secure, not just shoved in a dusty box to meet a quota. We should always aim for the ethical high ground, which usually keeps us safely above the legal baseline. So, what exactly counts as a medical error? So, what exactly constitutes a medical error? By definition, it is a failure in either planning or execution that leads to an unintended outcome. A failure in planning might be a doctor ordering the wrong test for a patient's symptoms. A failure in execution is when the right plan is in place, but it's carried out incorrectly. For us in histology, a failure in execution could be cutting a section too thick, rendering it unreadable, or leaving a slide in the hematoxylin too long. The key phrase here is unintended outcomes. Nobody wakes up and decides to make a mistake today. But when that failure in planning or execution happens, the patient suffers the consequences. It's important to recognize that an error doesn't necessarily mean someone was being malicious or lazy. It often means there was a breakdown in the process. Our job is to identify where those breakdowns occur, whether in the planning phase or the execution phase, and patch the holes. Let's look at some common types of these errors. Let's look at some of the most common types of medical errors. Misdiagnosis is a big one, and it's one where our work in the lab is heavily implicated. If the tissue isn't processed correctly, the pathologist might make the wrong call. Delayed diagnosis is another major issue. If we lose a specimen or take too long to process a rush order, the patient's treatment is delayed, which can be fatal in cases like aggressive cancers. Medication errors are incredibly common: wrong drug, wrong dose, wrong patient. While we don't administer drugs, we do manage hazardous chemicals, and mixing up reagents can ruin a whole batch of slides. Finally, there's the failure to follow up. This is when the test is done, the result is ready, but nobody tells the patient or acts on the information. It's like running a marathon and stopping 1 inch before the finish line. All of these errors have one thing in common: they are preventable with better systems and communication. And speaking of follow-up, there's one specific type of error that really causes problems. I want to highlight one specific error because it is the one that consistently gets people in trouble: the failure to follow up on test results. This is huge. It is a massive liability area and a frequent cause of patient harm. Think about it. The patient comes in, the doctor orders the biopsy, we do our magic in the lab, the pathologist writes a brilliant report diagnosing an early-stage melanoma. The system worked perfectly up to this point. But then, the report gets filed in the electronic health record, and the doctor never sees it, or sees it and forgets to call the patient. The patient assumes, "No news is good news," and goes about their life while the cancer grows. This is where the system often breaks down. It's a communication failure, pure and simple. While we aren't the ones calling the patient, we must ensure our results are delivered promptly and clearly to the right provider. We are part of that communication chain. So, why does this particular failure matter so much? We just talked about how a failure to follow up on test results is a huge liability area. So, why does follow-up matter so much? Because test results mean absolutely nothing if they are ignored. We could produce the most beautiful, perfectly stained slide in the history of histology, but if the doctor doesn't act on the pathologist's report, our work was useless. Delays in follow-up directly equate to a worsening condition for the patient. Time is tissue, as they say. The longer a disease goes untreated, the harder it is to cure. This intersection, the handoff of the result to the clinician, is exactly where the lab meets the patient outcome. We might never see the patient's face, but our work dictates their future. If we know a result is critical, we have an ethical obligation to ensure it is received and acknowledged. We can't just hit send and wash our hands of it. We have to be proactive in our communication, especially when dealing with critical values. That's how we protect the patient. Next, let's look at whether errors come from individuals or systems. When an error occurs, the instinct is usually to find someone to blame. Who messed up? But errors rarely happen in a vacuum. They can stem from individual mistakes, a tech who is distracted or poorly trained. But more often than not, they stem from systemic failures. A system failure is when the environment, the protocols, or the equipment set the individual up to fail. For example, if two patients with the same last name have biopsies on the same day, and the lab's labeling system is confusing, a mix-up is a system error waiting to happen. Often, it's a combination of both. An individual makes a mistake, and the system fails to catch it. In the lab, we have to look beyond the individual. If a tech mislabels a slide, we shouldn't just reprimand the tech, we should ask why the system allowed the mislabeling to go unnoticed. Fixing the system is how we prevent the next tech from making the exact same mistake. Now, let's wade into the legal waters and talk about negligence. We've discussed how errors can be individual or systemic. Now we are going to wade into the legal waters and talk about negligence. In legal terms, negligence is defined as the failure to act as a reasonably prudent person, but under similar circumstances. It is a departure from the standard of care. Imagine a hypothetical, perfectly average, sensible person. If that person would have double-checked the patient ID before cutting the tissue, and you didn't, you might be negligent. It's about heedlessness or carelessness. It's not about intentionally trying to hurt someone. It's about failing to take the necessary precautions to prevent harm. In the histology lab, negligence could look like skipping a quality control step because you were in a rush, or using an expired reagent because you didn't want to make a new batch. If that action leads to a misdiagnosis, you've departed from the standard of care. We are held to a professional standard, and failing to meet it has serious legal and ethical implications. But remember, not all errors are negligence. We just define negligence, but here is a very important distinction to keep in mind: not all errors equal negligence. An error can happen even when you are doing everything perfectly right. Sometimes equipment fails unpredictably, or a tissue sample behaves in a bizarre, unprecedented way. If you followed all protocols, exercised your best judgment, and a mistake still happened, that is an error, but it is likely not negligence. However, negligence is a type of error. It's the type of error that happens because you were careless, because you ignored the rules, or because you failed to act reasonably. Think of it like a Venn diagram. All negligence falls inside the error circle, but not all errors fall inside the negligence circle. The law recognizes that medicine is an inexact science and perfection is impossible. What the law punishes is a lack of reasonable care. So, don't panic every time a minor mistake happens. but do pause if you find yourself cutting corners. This leads us to the concept of malpractice. We've clarified that not all errors are negligence, but negligence is a type of error. When we talk about negligence in a professional setting, we use the term malpractice. Malpractice is simply professional negligence. Because we are trained professionals, whether you are a physician, a nurse, or a histotechnologist, society holds us to a higher expectation than the average person on the street. We have specialized knowledge and skills, and therefore, our reasonably prudent person standard is elevated to a reasonably prudent professional standard. If a random person on the street misreads a medical chart, it's not malpractice. If a doctor does it, it is. While we often associate malpractice with doctors getting sued, it applies to all healthcare professionals. If a histotech's gross negligence in processing a sample leads directly to a patient's injury, the lab and potentially the tech can be held liable for malpractice. Our training is a shield, but it's also a heavy responsibility. We are expected to know better and do better. Now, let's break down the 4 elements required to prove negligence. To prove negligence in a court of law, a plaintiff must establish 4 specific elements. It's not enough to just say, "They messed up and I got hurt." All 4 of these elements must be present and proven. We're moving from the general concept of malpractice to the specific legal requirements. They are duty, breach, causation, and damages. Think of them as the 4 legs of a table. If even one leg is missing, the whole negligence claim falls apart. We are going to go through each of these in detail, because understanding them helps you understand exactly where your legal liabilities lie. As you work in the lab, you should mentally check your actions against these 4 elements. Are you fulfilling your duty? Are you breaching the standard of care? Could your actions cause harm? Understanding this legal framework isn't just for lawyers. It's a practical tool for keeping yourself and your patients safe. Let's break them down one by one. The first element is duty. This means there must be a legal obligation to provide care or perform to a certain standard. In the classic sense, this is established by the physician-patient relationship. But what about us in the lab? We don't see the patients. Do we have a duty? Absolutely. When a specimen arrives in our lab, we assume a legal and ethical duty to process that specimen accurately, safely, and in a timely manner. Our duty is to the patient, even if they are just a name on a cassette. We have a duty to follow the standard operating procedures and maintain quality control. If you are assigned to the microtome, your duty is to cut readable sections. The duty is the starting line. Without a duty, there can be no negligence, but in healthcare, that duty is almost always present the moment we touch a patient's sample. Now, let's look at what happens when that duty isn't met. The second element is breach. This occurs when you fail to meet the standard of care associated with your duty. It is a deviation from accepted practice. If your duty is to process a specimen accurately, a breach would be mixing up 2 specimens. A breach can happen in 2 ways: doing something you shouldn't do, or not doing something you should do. For example, skipping the dehydration steps in the tissue processor because you want to go home early is a massive breach of duty. Failing to verify patient identifiers before embedding is a breach. The plaintiff has to prove that a reasonably prudent histotechnologist would not have made that same deviation. This is why standard operating procedures, SOPs, are so critical. They define the standard of care for your specific lab. If you follow the SOP, it's very hard to prove a breach. If you go rogue, you are opening yourself up to liability. But a breach alone isn't enough. We need to connect it to harm. The third element is causation. This is often the trickiest part to prove in court. Causation asks, did the breach of duty actually cause the harm? There must be a direct, reasonable, and close connection between your negligent act and the patient's injury. This is sometimes called proximate cause. Let's say you breach your duty by mislabeling a slide. The patient later dies of a heart attack that was completely unrelated to the biopsy you mislabeled. You breached your duty, but your breach didn't cause the death. Therefore, no negligence claim for the death. However, If your mislabeled slide resulted in the patient receiving the wrong chemotherapy, which then caused severe organ damage, the causation is clear. Your action was the direct link to the injury. The law looks for the but for rule. But for your mislabeling, would the patient have suffered that specific harm? If the answer is no, you have causation. And finally, we need to see actual harm. The final element is damages. For a negligence claim to succeed, actual harm must have occurred. You can't sue someone just because they made a mistake if that mistake didn't hurt you. Damages can be physical, like an unnecessary surgery or a worsened disease state. They can be emotional, like the severe distress of being falsely diagnosed with cancer. And they can be financial, like the cost of additional medical care or lost wages. If you mislabel a slide, but the pathologist catches the error before the report goes out, you breach your duty, but there are no damages to the patient. It's a near miss, a good catch, but it's not legal negligence because no harm occurred. However, don't let that make you complacent. A near miss is a giant red flag that your system is flawed. You might have dodged the damages bullet this time, but if you don't fix the breach, the damages will eventually happen. Remember, all 4 of these elements must be present. So, to really hammer this home, you need all 4 elements to prove negligence: duty, breach, causation, and damages. If even one of these is missing, the legal claim for negligence falls apart. Think of it like a table. If it's missing a leg, it just won't stand. Understanding this framework isn't about finding loopholes to get away with bad behavior. It's about knowing exactly how the law evaluates your actions. By understanding what constitutes a breach and how it links to causation and damages, you can better evaluate your own daily practices. This knowledge makes you a safer, more conscientious tech. It protects you from liability, and more importantly, it protects the patient from harm. Keep these 4 elements in the back of your mind every time you step up to the bench. Now, let's talk about the messy reality of ethical dilemmas. As we transition from those clear legal definitions, it's important to acknowledge the gray areas we often encounter. Not every situation you face will be a simple case of right versus wrong, or legal versus illegal. You'll often find yourself in ethical dilemmas where 2 important values clash. For instance, you might need a rapid diagnosis for a critical patient, but that might conflict with the need for thorough, time-consuming tissue fixation. These gray areas are where your ethical compass truly gets tested. There isn't always a perfect answer, but there's always a thoughtful, patient-centered approach. Learning to navigate this uncertainty, to consult with colleagues, and to make defensible decisions is a hallmark of an experienced professional. The goal isn't to always have the right answer, it's to always ask the right questions. This leads us to 2 broad categories of errors. Let's break down the types of failures that lead to these breaches of duty. Broadly speaking, failures fall into 2 categories: acts of commission and acts of omission. An act of commission is doing something wrong, it's taking an incorrect action. An act of omission is failing to act when you should have, it's not doing something right. Both can be equally devastating in their impact on patient care. In the eyes of the law and ethics, failing to do something necessary is just as bad as actively doing something harmful. It's the difference between driving through a red light and failing to hit the brakes when a pedestrian is in the crosswalk. In healthcare, we have to be vigilant against both. We must ensure we are taking the correct actions and that we aren't neglecting the necessary ones. Let's look at some specific examples of each to make this concrete. Examples of commission are usually the more obvious errors we think about. In a clinical setting, it's administering the wrong medication or performing surgery on the wrong patient. These are active, affirmative mistakes. In the histology lab, an act of commission would be using the wrong stain for a specific tissue type, completely ruining the diagnostic value of the slide. Or the classic nightmare, actively mislabeling a cassette with the wrong patient's name. You took an action, and that action was incorrect. These errors often stem from rushing, distraction, or poor training. They are the oops, I shouldn't have done that moments. Preventing acts of commission usually involves strict adherence to protocols, barcode scanning, and multiple double checks. We have to build systems that make it hard to do the wrong thing. But what about the errors that are harder to spot? Acts of omission are sometimes harder to catch because they involve the absence of an action. In the clinic, it's the failure to follow up on a critical test result, or missing a glaring symptom during an exam. In the lab, an act of omission could be failing to run a positive control slide alongside a patient's special stain. If you omit the control, you have no way of knowing if the stain actually worked, which compromises the patient's result. Or, it could be failing to notify the pathologist when you notice a discrepancy between the tissue received and the requisition form. Acts of omission are incredibly common, often more so than commission. They happen when people are overworked, when communication breaks down, or when someone assumes it's not my job. Preventing omission requires a culture of accountability, where everyone feels responsible for the entire process, not just their small piece of it. Next, we'll dive into some specific legal terms for these types of failures. We've talked about acts of omission, and now we're diving into a specific, severe type, nonfeasance. This is when you simply failed to act when you have a clear duty to do so. It's not doing something you were required to do. For example, if your lab's protocol mandates daily temperature checks on the water bath, and you just skip it for a week, that's nonfeasance. You had a duty to perform that check, and you ignored it. This isn't about doing something wrong, it's about doing nothing when action is required. In healthcare, doing nothing when action is needed can be just as dangerous as doing something incorrectly. It's a failure of responsibility that can lead directly to patient harm and legal trouble. Next, we'll look at what happens when you do act, but you do it badly. Now let's move on to misfeasance. This is different from nonfeasance because here, you are actually performing an act, but you're doing it improperly. It's doing the right thing, but doing it badly. Think of it as a botched execution. For instance, if your job is to cut sections on the microtome, and you do it so carelessly that the tissue is shredded and unusable, that's misfeasance. You performed the correct task, but your execution was flawed, leading to a poor outcome. This often points to a need for better training, more attention to detail, or perhaps even better equipment. It's the "I tried, but I messed it up" category, and it can be just as damaging as not acting at all. But what about when you do something you shouldn't be doing at all? We'll cover that next. Finally, we have malfeasance, which is the most serious of these three categories. Malfeasance is when you perform an act that is unlawful or inherently improper. It's doing something you have absolutely no right or authority to do. This isn't just a mistake. It's a blatant violation of rules and often involves intentional wrongdoing or gross recklessness. For example, if a histotechnologist attempts to issue a diagnostic report on a slide, that's malfeasance. We are not pathologists, and we are not licensed to diagnose. Acting outside your scope of practice in such a significant way is a quick path to losing your job and your license. It's a clear line that should never be crossed. Now that we've covered these types of failures, let's define the benchmark against which all our actions are measured, the standard of care. We've been throwing around the term standard of care quite a bit, so let's get a clear definition. The standard of care is the benchmark for all professional conduct. It's what a reasonably competent professional, with similar training and experience, would do in a given situation. This isn't some abstract ideal, it's grounded in the reality of everyday practice. For us, it's what other competent histotechnologists would do. Would they verify patient IDs before embedding? Yes. So, that's the standard. This standard is established by professional organizations, textbooks, and our lab's standard operating procedures. It's a dynamic concept, evolving as technology and knowledge advance. Staying current with your continuing education isn't just a good idea, it's how you ensure you're meeting the modern standard of care. This leads us to the concept of the reasonably prudent person. Let's demystify this reasonably prudent person, or reasonably prudent professional that the law often refers to. This isn't some superhero of healthcare. This person isn't perfect, and they're certainly not an infallible robot. They're not expected to provide the absolute best care imaginable in every single scenario. Instead, they are simply expected to be reasonable, competent, and careful. They represent the average, sensible professional in your field. If you make a judgment call that turns out to be wrong, but a jury of your peers agrees that they might have made the same call under those specific, stressful circumstances, then you likely acted as a reasonably prudent professional. The standard is designed to punish carelessness and incompetence, not honest mistakes made in good faith by competent people. It's a standard of reasonableness, not a standard of perfection. But remember, a bad outcome doesn't automatically mean negligence. Here's a crucial reminder, perhaps the most important point in this section: a bad outcome doesn't automatically equal negligence. Medicine is inherently risky, and sometimes, despite perfect care, the patient still has a bad outcome. Just because a patient suffers harm doesn't mean someone committed malpractice. To prove negligence, the plaintiff must prove there was a deviation from the standard of care. They have to prove the bad outcome was caused by someone failing to act reasonably. If you processed a difficult tissue sample to the best of your ability, following all protocols, and the slide is still suboptimal, that's a bad outcome, but it's not negligence. You met the standard, the tissue just didn't cooperate. This distinction is vital for understanding your liability. Now, let's see how ethics plays into setting that standard of care. So, how do ethics tie back into the standard of care? They're deeply intertwined. Ethical principles often influence and shape what the law considers to be acceptable care. Professional codes of ethics, like those from the American Society for Clinical Laboratory Science, set the bar for how we ought to behave. Over time, these ethical guidelines become the accepted standard of practice, which courts then use to determine legal liability. If you violate a core ethical tenet of your profession, you're very likely also breaching the legal standard of care. Ethics leads the way, and the law follows closely behind. This means our ethical compass isn't just a nice-to-have, it's foundational to our legal responsibilities. Next, we'll dive into some common points where these standards often break down. Let's look at some real-world error patterns. Where do things actually fall apart on a daily basis? The number one culprit, across all of healthcare, is communication breakdown. It's the handoffs, the missed calls, the critical info lost during a shift change. Second is poor documentation. If it isn't written down, it didn't happen. Incomplete or illegible records lead to massive confusion and errors down the line. Third is delayed action. Sitting on a critical result, or taking too long to process a stat biopsy. These three failure points, communication, documentation, and delays, are the Bermuda Triangle of medical errors. If we can tighten up these three areas in the lab, we can drastically reduce our error rates. Now, let's get specific about how these failures manifest in diagnostic errors. Diagnostic errors are a major category of failure, and this is where the histology lab has a direct, undeniable impact. A misdiagnosis is when a disease is present but not identified. A delayed diagnosis is when it's identified, but much later than it should have been. Both can be catastrophic for the patient. How do we contribute to this? If we over-decalcify a bone marrow biopsy, we might destroy the cellular detail needed to diagnose leukemia. That's a misdiagnosis caused by the lab. If we lose a specimen block and have to spend 3 days hunting for it, that's a delayed diagnosis. The pathologist can only diagnose what they can see on the slide. We are the ones who create that vision. If our work is flawed, the diagnosis will be flawed. We hold the key to accurate diagnostics. And these diagnostic errors often lead directly to the next type of problem: treatment errors. Treatment errors occur when the wrong intervention is chosen, or the right intervention is delayed. These errors are often downstream consequences of diagnostic errors. If the diagnosis is wrong because of a lab mix-up, the treatment will be wrong. Imagine a patient receiving aggressive radiation therapy for a tumor they don't actually have, all because 2 cassettes were swapped at the grossing station. That is a treatment error born from a lab error. Treatment errors can also happen if the clinician misinterprets the lab report, or if the report is ambiguous. This highlights the need for clear, standardized reporting, and open lines of communication between the lab and the clinical team. We must ensure the information we provide is not just accurate, but also easily understood, so it leads to the correct treatment. And speaking of communication, let's revisit a critical area where things often fall apart: follow-up failures. We're circling back to follow-up failures because they are that important. This is a huge liability area. This happens when the lab does everything right, the pathologist makes the correct diagnosis, the report is finalized, and then nothing. The results are ignored, or the patient is never contacted. The ball is dropped on the 1-yard line. While the primary responsibility for patient contact lies with the physician, the lab isn't entirely off the hook. We have systems for critical values, results that indicate a life-threatening situation. If we have a critical value, we can't just put it in the computer. We have to call and speak to a human being and document that conversation. If we fail to follow our own critical value reporting protocols, we become part of the follow-up failure. We have to ensure our results actually reach the people who need them. Next, let's consider how monitoring can also fail. The last common error pattern is monitoring failures. This is when a patient is on a treatment plan, but nobody is checking to see if it's actually working, or if it's causing harm. There is no reassessment and no adjustment. In the clinical world, this might mean failing to check liver enzymes for a patient on a toxic drug. In the lab world, monitoring failures relate to our quality assurance programs. Are we monitoring our stain quality over time? Are we tracking our error rates? If we notice that our H&E stains have been slowly getting weaker over the last month, but we don't adjust the protocol or change the reagents, that is a monitoring failure. We are failing to track our own progress and correct our course. Continuous monitoring is essential for maintaining high standards and catching small drifts before they become major errors. So, what happens when an error inevitably slips through? So, the worst has happened. An error occurred. What happens next? This moment, right after the mistake is discovered, is where true professionalism shows. It is the ultimate test of your character and your ethics. Anyone can be a good professional when everything is going smoothly. But how do you react when you realize you just embedded the wrong tissue, or you accidentally discarded a precious sample? The instinct is often panic, followed by a desire to hide it. But hiding it is the absolute worst thing you can do. The aftermath of an error is a critical juncture. The actions taken in the next few minutes and hours will determine whether the error is mitigated or compounded. It's a moment that requires courage, honesty, and a steadfast commitment to patient safety above your own ego or fear of reprimand. Let's talk about the ethical way to respond. The ethical response to an error involves 3 steps. First, acknowledge the error immediately. Don't deny it, don't minimize it. Own it. Second, communicate honestly. Tell your supervisor or the pathologist exactly what happened, without making excuses. I accidentally dropped the slide and it shattered. Clear, direct communication allows the team to assess the damage and formulate a plan. Third, act to correct it. If there is a way to salvage the situation, maybe there is more tissue in the block, or maybe the clinician can be notified before they act on a flawed report, do it immediately. The ethical response is focused entirely on damage control and patient safety. It's about putting the needs of the patient ahead of your own discomfort. It's hard, it's embarrassing, but it is absolutely necessary. Now, let's talk about what you absolutely should not do. Now let's talk about what not to do when an error occurs. Do not ignore it, hoping it will just go away. It won't. Medical errors have a nasty habit of snowballing. Do not hide it. Covering up a mistake is often worse than the mistake itself. It turns an act of negligence into an act of malfeasance and fraud. If you hide a mislabeled slide, you are actively participating in a false diagnosis. And finally, do not blame others. Don't point fingers at the grossing tech, or the courier, or the equipment, unless there is a genuine system failure that needs addressing. Deflecting blame destroys team morale and prevents the root cause of the error from being discovered. Ignoring, hiding, and blaming are the hallmarks of an unprofessional and dangerous work environment. We must cultivate a culture where it is safe to admit mistakes. After discussing what not to do when an error occurs, let's talk about our responsibility to report. This isn't just about admitting your own mistakes. It's about speaking up when you see unsafe behavior or conditions in the lab. If you notice a colleague cutting corners or working while impaired, you have an ethical and professional obligation to report it. This isn't about being a tattletale. It's about protecting patients who can't see what happens behind the lab doors. Turning a blind eye to dangerous practices makes you complicit in any harm that might result. Reporting isn't optional. It's mandated by many professional codes and hospital policies. It can be tough, but your loyalty must always be to patient safety. This commitment to safety ties directly into the broader ethical frameworks that guide our profession. Building on the idea of reporting, every healthcare profession operates under a code of ethics, and ours is no different. While the specific words might change, all codes demand three core values: integrity, accountability, and competence. Integrity means always doing the right thing, even when no one is watching, and never falsifying records. Accountability means taking full responsibility for your actions and their outcomes, owning your mistakes. Competence means having the skills and knowledge to do your job safely and effectively, and committing to continuous learning. These aren't just fancy terms, they are the bedrock of our profession. As histotechnologists, we must embody these values daily. Our code of ethics isn't just a document, it's the lens through which we should view every single slide we touch. These ethical principles are especially important when we consider our unique role in the lab. So, what exactly is your role in the lab, especially in this ethical context? You might never see the patient, never hold their hand, or hear their story. It's easy to feel disconnected, to see tissue as just a sample, not part of a person. But you are the invisible frontline of diagnostics, and your work affects patients directly and profoundly. The quality of your sections, the precision of your stains, the accuracy of your labeling, these are critical. They determine whether a pathologist can make the right call. If you fail, the diagnosis fails, and the patient suffers. Always remember that behind every accession number is a human being anxiously awaiting answers. Treat every specimen as if it belonged to your own family. This understanding helps us grasp the gravity of potential lab errors. Let's get specific about what lab errors actually look like in our field. Mislabeling is the classic, terrifying example. Swapping two cassettes means two patients get the wrong diagnosis. An incorrect result can stem from using expired reagents, poor staining technique, or failing to run controls, leading to misinterpretation. Delayed reporting happens when specimens are misplaced, equipment breaks down, or workflow is poorly managed, causing agonizing waits. And then there's specimen loss, accidentally discarding a biopsy or destroying it in the microtome. When a specimen is lost, especially a small biopsy, it might be irreplaceable. The patient might need another invasive procedure, or worse, lose their chance at a diagnosis entirely. These are the real-world challenges we face, and they lead to very real consequences. The consequences of these lab errors are incredibly real and severe. A mislabeled slide directly leads to a misdiagnosis. One patient is told they are fine when they have cancer, and another is told they have cancer when they are fine. This then leads to the wrong treatment. The healthy patient undergoes unnecessary surgery or toxic chemotherapy, suffering immense physical and emotional trauma. The sick patient receives no treatment, allowing their disease to progress unchecked. This is the ultimate patient harm. The ripple effect of a single lab error is massive, affecting the patient, their family, the treating physician, and the entire healthcare institution. It leads to lawsuits, loss of accreditation, and shattered lives. We are not just making slides, we are handling the blueprints for patient care. The stakes could not be higher. So, what is our ethical responsibility to prevent these nightmares? What is our ethical responsibility in the lab to prevent these nightmares? It boils down to 4 pillars. First, accuracy. We must strive for perfection in every technical step, from grossing to staining. Second, verification. We must constantly double-check our work and the work of our peers. Trust, but verify. Third, communication. We must communicate clearly with pathologists, clinicians, and each other. If something looks wrong, say something. If a specimen is compromised, report it immediately. Fourth, quality assurance. We must actively participate in QA programs, tracking our errors, analyzing our processes, and constantly looking for ways to improve. Our ethical responsibility isn't just to do our job, it's to do it safely, accurately, and with a relentless commitment to continuous improvement. This commitment helps us build robust defenses against errors. Have you ever heard of the Swiss cheese model of medical errors? Imagine your lab's safety protocols as slices of Swiss cheese. Each slice is a defense layer, barcode scanning, double checks, SOPs. But every slice has holes, representing weaknesses or potential failures in that specific defense. Usually, if an error slips through one hole, it's caught by the next slice. But sometimes, the holes in all the slices align perfectly. The tech is distracted, the barcode scanner is broken, and the pathologist is rushed. When those holes align, the error passes through all defenses and reaches the patient. Our goal in the lab is to add more slices of cheese and make the holes as small as possible. We layer our defenses so that a single failure doesn't result in a catastrophe. And one of those holes can often be fatigue. Let's talk about a very real, physical cause of errors: fatigue. The lab can be a grueling environment. Long hours, high volume, and repetitive tasks take a toll. Studies consistently show that as fatigue increases, error rates skyrocket. Your attention to detail drops, your reaction time slows, and your judgment becomes impaired. Burnout is a massive issue in our field. It's not just feeling tired, it's a state of emotional and physical exhaustion that leads to cynicism and detachment. When you are burned out, you are far more likely to make a mistake and dangerously less likely to care. It is an ethical imperative to recognize your own limits. If you are too exhausted to work safely, you need to speak up. Pushing through fatigue isn't heroic, it's a liability. Your supervisor would much rather you say "I need a break" than find out you mixed up 2 specimens because you were running on fumes. This is especially critical when we consider a scenario like a mislabeled biopsy. Let's look at a hypothetical, but very realistic, case study. 2 patients have prostate biopsies on the same day. The grossing tech is rushed and accidentally swaps the tissue into the wrong cassettes. Patient A, who has cancer, gets patient B's benign diagnosis. Patient B, who is healthy, gets patient A's cancer diagnosis. Patient B undergoes a radical prostatectomy, suffering life-altering side effects for a cancer he never had. Patient A's cancer goes untreated and spreads. This is the nightmare scenario. It all started with a momentary lapse in concentration at the grossing bench. This case highlights how a simple act of commission, putting the wrong tissue in the wrong box, can destroy multiple lives. It's a stark reminder of why our protocols exist, and why we must never rush through specimen accessioning. Now, let's break down how this could have been prevented. Let's analyze that case study. Where did the system fail? It wasn't just the tech's mistake. Why were 2 similar specimens open on the bench at the same time? That's a system failure. How could it be prevented? Many labs now implement a single-piece workflow or one-at-a-time rule. You only open one patient's container, process it, cassette it, and close it before moving to the next. You never have 2 patients' tissues exposed simultaneously. Barcode scanning at every step also forces verification. By analyzing errors like this, we move away from blaming the tech and focus on building a workflow that makes swapping cassettes physically impossible. That is how we apply ethics to process improvement. It's not about punishing the individual, it's about designing a system that protects everyone. And this kind of error has serious legal ramifications. So, what is the legal fallout of that swapped biopsy case we just discussed? It's massive, and it's a nightmare scenario for everyone involved. Patient B will absolutely file a malpractice suit for the unnecessary surgery and the resulting damages. Patient A will also sue for the delayed diagnosis and the worsened prognosis. The hospital and the laboratory will be named as defendants because they are responsible for the systems and the employees. But here's the kicker: the individual tech who swapped the cassettes could also be named personally in the lawsuit. Remember the 4 elements of negligence? Duty, breach, causation, and damages? All 4 are clearly present in this scenario. It's a clear-cut case of negligence, and the financial and professional penalties will be severe. This is why documentation, SOPs, and training records are your only defense. Let's talk about how to build that defense. If you ever find yourself involved in a malpractice suit, your best defense is your documentation. The plaintiff's lawyer will try to prove you breached the standard of care. Your defense is to prove you followed it perfectly, every step of the way. If your logs show you performed all required maintenance, if your training records show you were competent on that procedure, and if you followed the SOP to the letter, it is much harder to prove negligence. The SOP is your shield in these situations. If you deviate from it, you throw your shield away and leave yourself exposed. This is why we harp on documentation so much in this course. It feels like tedious paperwork in the moment, but 5 years down the line, when you are sitting in a deposition, that logbook is the only thing standing between you and massive liability. So document everything. If it isn't written down, it didn't happen in the eyes of the law. Beyond individual defense, we need to build a culture of safety in our labs to prevent these issues from happening in the first place. A culture of safety is one that encourages blame-free reporting. It recognizes that humans make mistakes and focuses on fixing the system rather than punishing the individual, unless there is gross negligence. In a culture of safety, we celebrate the reporting of near misses. These are those errors that were caught just in time, because they highlight vulnerabilities in our processes before actual harm occurs. We use those near misses as learning opportunities for continuous improvement. If you work in a lab that punishes honest mistakes, people will hide them. But if you work in a lab that learns from mistakes, people will report them, and the lab will become safer for everyone. We all have a role in fostering that positive, safety-oriented culture. Let's do a quick review of the core ethical principles that should guide our practice, because they are the foundation of that culture of safety. We discussed non-maleficence extensively. First, do no harm. Beneficence is the flip side of that coin. It means actively doing good and acting in the best interest of the patient. Autonomy respects the patient's right to make their own healthcare decisions, which relies on us providing accurate information for informed consent. And justice means treating all patients fairly and equitably, ensuring that the quality of our lab work doesn't vary based on who the patient is or what their background is. These 4 principles, non-maleficence, beneficence, autonomy, and justice, are the compass points that can help us navigate any ethical dilemma we encounter in the lab. Tattoo them on your brain, because they are that important. Now, how do we keep these principles sharp? That brings us to the importance of continuing education. The field of histotechnology is constantly evolving. New stains, new molecular techniques, new automated systems are introduced all the time. The standard of care today will not be the standard of care 10 years from now. If you stop learning the day you graduate, you will quickly become obsolete and, frankly, dangerous to your patients. Continuing education is not just a requirement to keep your certification, it is a fundamental ethical obligation. You owe it to your patients to provide care based on the most current, scientifically sound practices. Embrace lifelong learning. Stay curious, stay engaged, and never assume you know everything. That humility is the mark of a true professional. The day you think you know it all is the day you become a liability, and we don't want that. As we wrap up, I want to leave you with a key question to ponder. What would you do? Ethics and law are easy to discuss in a classroom, but they are much harder to apply when you're 3 hours into a busy shift and realize you might have just swapped 2 blocks. What would you do when the pressure is on? What would you do when you make a mistake and you're absolutely certain no one else saw it, and no one will ever know? That is the true test of your professional ethics. Will you take the easy way out and hide it, risking patient harm? Or will you take the hard road, admit the mistake, and protect the patient? Your answer to that question defines the kind of histotechnologist you will be. Choose wisely, because your integrity is on the line. This leads us to our final takeaway. Here is your final takeaway for today. Mistakes happen. They are an unavoidable part of complex healthcare systems. But while we can't eliminate mistakes entirely, we can control how we respond to them. Accountability matters, and we must own our actions and their consequences. When the rules of law are unclear or insufficient, our ethics must guide our response. We must always default to what is best and safest for the patient. Remember that professionalism isn't defined by how well you cut a slide on a good day. It is defined by how you handle yourself in the most difficult, stressful, and error-prone moments. It's about having the integrity to do the right thing when it's the hardest thing to do. Carry that with you as you move forward in your careers. You've got this, and you'll see why you are so essential. As we conclude this lecture, I want to leave you with this thought: you are essential. The healthcare system cannot function without the work you do in the histology lab. You are the foundation upon which accurate diagnoses and effective treatments are built. Your work matters deeply to every single patient whose tissue crosses your bench. Never lose sight of that importance. Take pride in your precision, uphold the highest ethical standards, and always remember that you are a critical guardian of patient safety. The pathologist needs you. The physician needs you. The patient needs you. Never underestimate the weight and the privilege of that responsibility. Thank you for your attention today, and I look forward to seeing you apply these principles as you move forward in your careers. Now, let's open it up for questions. We've covered a lot of heavy material today, from the Hippocratic Oath to the legal elements of malpractice, and the harsh realities of lab errors. I know it can be a bit overwhelming to think about the liability and the potential for harm. But knowledge is power. By understanding these risks, you are better equipped to prevent them. Now, I want to open the floor. What are your thoughts? Have any of you experienced or witnessed a near miss in your clinical rotations? How was it handled? Was there a culture of safety, or was it swept under the rug? Let's use the remaining time to discuss these concepts and how they apply to the real-world scenarios you are starting to encounter. Don't be shy. This is the safe space to ask the hard questions. No judgment, no wrong answers, just honest, professional conversation.